Jan just went through with you how to create cohort definitions. And Jan made a bold assertion that was the most important tutorial of the day. So, I want you to raise your hand if you believe that that was the most important tutorial of the day. I want you to stand up if you think it was the most important tutorial of the day. I want you to stand up and wave your hands if it was the most important tutorial of the day. Okay, very good. A little extra blood flowing here. Definitely was the most important tutorial of the day, although we really do want to give you a lot of exposure to a lot of different pieces. But the reason why I would agree with Jan that it was the most important lecture of the day is because if you don't understand how to build reliable cohorts, you can't generate reliable evidence across any of our different analyses. And the rest of the day, now that we've had lunch, we're going to go through how to do characterization analyses, how to do estimation analyses, and how to do prediction analyses. All of them are going to require that you are able to create reliable cohorts. So, raise your hand if you understood what you were doing in Atlas to create cohorts. I see like half hands, like kind of, sort of. Okay, so, excuse me. So, in this first segment, so I'm going to do 2 segments in a row here. In this first one, we're going to work on creating cohorts some more. But I'm going to specifically try to focus on how to create cohorts where you can evaluate to understand whether or not you've done the right thing in defining your cohort. And then after that, I'm going to walk into, given that you have a cohort, how do we perform characterization analyses? So, in order to talk about phenotype, let me back up. What Jan was presenting to you was phenotype development. The idea you were creating cohort definitions using Atlas. And Jan showed you how to create 2 cohorts. One was new users of lisinopril who had previous hypertension. And then the second one that he created was acute myocardial infarction events. Now, if we take those 2 different cohorts, the question that I'm going to be posing during this segment is, how do we know that we found the right people when we created those cohort definitions? So, for example, Jan went through it pretty quickly, but he created a new user cohort of lisinopril where he said, you must have a drug exposure record of lisinopril. And then he created an inclusion criteria which says, must have hypertension in the prior 365 days. And Jan's assertion was that those are the people that we want to study, the people who took lisinopril who previously had hypertension. Does anybody remember, we put it up on the screen relatively quickly, but does anybody remember what percentage of new users of lisinopril had prior hypertension? It popped up in the screen when he was showing the attrition table. Did anybody see that? Jan, what was the number? 76%. So 76% of new users of lisinopril had a record in their history of having hypertension. So the question is, what about those other 24%? Lisinopril as a drug is indicated for hypertension. So if you observed a person getting a drug of lisinopril, one of 2 things must be true. Either, actually I guess maybe 3 things could be true. Number 1, they got a record that says that they were exposed to lisinopril, but they never actually got lisinopril. That's possible. Number 2, they took lisinopril for a different reason other than hypertension. So that's possible. Or number 3, they took lisinopril for hypertension, They just didn't have hypertension recorded in their record. But what Chan showed you was that in this database, under the definition that he used, 24% of patients who took a drug that's only for hypertension didn't have hypertension in their record before the exposure. And so those three situations that I just suggested are all potentially sources of error. And the question is, how do we figure out what that error actually is? And so this section that I'm going to talk about, phenotype evaluation, is how do we create a definition and then try to determine whether or not we can trust that we are reliably identifying the patients of interest. And with thanks to Gautam Rao, who prepared this part of the tutorial in the US a couple weeks ago, I'm going to borrow some of his slides. So what I'm going to try to cover is first to talk about the importance of measurement error in phenotyping. And then I'm going to do a live demonstration where we're going to explore Chan's definition of acute myocardial infarction. And then you all are going to do your own phenotype evaluation to try to understand the measurement error of angioedema. So when we create a cohort, we are trying to identify a set of persons who satisfy one or more inclusion criteria for a duration of time. That's that definition of a cohort that Chan laid out for you. And a challenge when we do that is we usually have some clinical idea in mind, like patients who've had a heart attack or myocardial infarction, or patients who've had angioedema, or patients who have hypertension. In each of those cases, there can be three types of measurement error that we need to be watching out for. There can be sensitivity errors. That is to say, there's some reason why your definition does not find all of the people who truly have the clinical idea of interest. There can be specificity errors. That is to say that you identify people who don't really have the disease that you're interested in. And there can be index date misspecification errors. This is to say that the date that you assigned the person to enter the cohort is wrong. All of these errors can impact our ability to generate reliable evidence. If we have sensitivity errors, that means we're not finding all of the people who have the events of interest. So if we are interested in studying how often do people who are new users of lisinopril go on to have myocardial infarction, it's very important that we know we're finding all of the myocardial infarctions. Otherwise, we could underestimate the risk of having a heart attack. Specificity errors are really important, though, because if a whole bunch of the people that we claim have heart attacks never actually had a myocardial infarction, then we could overstate the risk associated with that, with exposure. And index date misspecification is an area that a lot of people don't appreciate, but I'll provide a more topical example where this is very relevant. Hopefully many of you have received a vaccine for COVID-19, which have been proven to be very effective treatments and largely safe. But safety or risks associated with vaccines usually are things that we're worried about within a short period of time right after you get vaccinated. We usually talk about the risks of vaccines being within the first 1 month after being vaccinated. It turns out that when Chan was showing you that one of the important criteria of creating a cohort definition is to define the entry event. It's the date when you assert that an event happens. Well, some outcomes, the date that you have in your system could be wrong. Wrong by days or weeks or sometimes even months. And if you have an incorrect date and you are using that date to determine whether or not an outcome occurs proximal to exposure, you can miss events in multiple directions. In our case, imagine we were to say lisinopril we are looking for angioedema events that occur within the first 30 days following exposure, which is usually when people are most worried about these types of acute adverse reactions. Well, if you were to find that the date for an angioedema event is wrong by a couple weeks, then you could actually get the timing between when you were exposed and when you had the outcome in the wrong order. This is not very well described in the literature, but we have now seen numerous occasions where what seem to be relatively small issues associated with index date and specification can completely change the answers that you produce when you're characterizing incidence or estimating the relative risk. And as it relates to the COVID vaccines, this is particularly important associated with the known risk of myocarditis that was observed and the specific observation associated with an increased risk after a second dose of the mRNA vaccines, where getting the timing right of when did myocarditis actually happen is one of these areas where it can be a little bit fuzzy. So, given that these are the types of errors that we are concerned about, the question is, how can we investigate our data to determine if we have any of these types of errors and to think about what to do about them? So, just to summarize briefly in words, a different way to frame this. Chan described that we have a phenotype, which is that clinical idea of interest, or a disease that we are trying to model. And we create a cohort definition, which is a manner in which we are trying to find the people who have that clinical idea of interest. But because we are now translating the clinical idea into code, which is the logic we apply to data to identify the patients, that translation of the idea to code is where there may be measurement error. That measurement error could either be due to problems in the data or problems in the logic that you created that's applied to the data. So our goal is to try to understand how much of this measurement error actually exists, what types of measurement error do we observe, and in a more idealized world, correct our analyses for the amount of measurement error that we've identified. So we would like to be able to estimate measures of sensitivity, specificity, and positive predictive value. These are metrics that are commonly associated with quantifying measurement error. What we observe in our field of in epidemiology and real-world evidence is that while we would like to understand these metrics, it's quite uncommon that people actually estimate them. Rather, we sometimes see people do a sample of chart review, whereby they identify some group of people who are identified by the phenotype definition. They have clinical adjudicators look through those cases and determine the proportion of those cases that are actually real events. And that gives you an estimate of positive predictive value. However, understanding how many cases you missed, or understanding the extent to which cases that you did not identify are true events, are challenging to do if you're doing chart review. And so within OHDSI, we've been developing a series of different tools to help us better understand this measurement error. And we're going to play with one of them today. So just to reiterate, we're going to talk about sensitivity error. So this is the idea that we might be able to observe evidence in our data that there are people who do have the event, but we didn't identify. That is to say, we have not defined a definition that finds all of the people that truly have the disease. And that's one error for which we're going to look for something in the data that tells us about that problem. Another error is specificity error. We're going to use our data to try to uncover whether or not there are people who we've identified in our algorithm that don't look like they might actually have the disease of interest. And in the index date in the specification, we're going to look for evidence that may suggest to us that the date we assigned individual patients might be incorrect one way or the other. So one of the main contributions that we've made in this space that I think is exciting is we're going to now use our data to try to understand measurement error in a systematic way. So, as a general process that we recommend following for phenotype development evaluation, Chan showed you the first component of this, which is to create a phenotype. And basically the process that he walked through was, given some clinical idea, like myocardial infarction, we created concept set expressions, we created cohort definitions. He demonstrated this using the Atlas tool. What I'm going to show you is how we can use a definition like what Chan produced to use the data to evaluate that definition. And I'm specifically going to show you a tool called cohort diagnostics, which tries to characterize your data set in a way that helps you understand whether or not you can trust your definition. We very much see this as an iterative process, that you can learn about your definition, to learn that you need to modify it, and you can continue to iterate until you feel confident in the definition that you have. At the end of this process, what we hope to have produced is a definition that you can use, that you feel good about, but also a quantification of why you feel confident about your definition. We think that this is an important component for us to be able to generate reliable evidence. So, I'm going to walk you through briefly how we can use cohort diagnostics to study acute myocardial infarction definitions. And then I'm going to have you all go through the process yourselves with the support of all of our TAs in the room to explore angioedema as your outcome. So as I go through here, I'll walk through how to do this for acute myocardial infarction. I want you to be thinking about how am I going to do that same thing for exploring angioedema. So first things first is it's important that you have some grounding of the clinical idea that you're trying to find, such that when we look in the data set, we can try to determine whether the data supports the idea you have in mind. One simplification of this to think about is that if we're studying a disease like acute myocardial infarction, then we could try to identify what factors would we observe in the data that would strengthen our belief that a given person actually has a heart attack, and what things might we observe in the data that would disqualify a person from having the event, because observing that would be inconsistent with having the disease. So examples of strengtheners in this case could be things like signs and symptoms, any sort of diagnostic procedures that a patient may encounter, as well as any treatments. So for example, for acute myocardial infarction, oftentimes a patient who's had a heart attack will initially complain of chest pain, will arrive in an emergency room or some acute, urgent care setting, and at that time, if there's suspicion of a myocardial infarction, clinicians may perform some sort of diagnostic electrocardiogram to be able to assess whether or not they see any sort of myocardial imbalance. If there is observed ischemia, then a patient may be immediately treated, which would often involve aspirin and beta blocker use to try to minimize the acute disruption. And there would be some follow-up care, which could involve, for example, a surgical procedure like a PCI or CABG as a surgical intervention, followed by some regular course of cardiovascular drug treatment that would follow up as a result. So in a perfect case, if we had a real myocardial infarction, you would see all of those strengthener events happen. You'd see the chest pain, you'd see the admission to the hospital, you would see the EKG, you would see the beta blocker, and you'd see the PCI surgery. If you saw all of those things, you'd probably feel pretty confident that you're looking at a legitimate myocardial infarction. However, in our data, it's not often the case, it's not always the case, that every patient is going to look that clean cut. Instead, there could be some person who, for example, shows up complaining of chest pain. A doctor rightfully orders an electrocardiogram to determine whether or not there's some myocardial imbalance, does not observe any such thing, and then discharge the person and send them home. In some healthcare systems, in many healthcare systems, that suspicion of that there might be a myocardial infarction will result in the code for myocardial infarction being written down in the person's medical record, particularly for administrative claims data, where the justification for billing for the electrocardiogram is the fact that we're worried that the patient may have had a heart attack, may be the reason why a myocardial infarction would be recorded in a record. So in this case, the patients start the same. They have the same symptom, chest pain. They have the same diagnostic procedure, electrocardiogram. However, one goes on to have treatment and another does not. And our challenge as we create these phenotype algorithms is how do we actually discriminate between those two different events. So, when we're thinking about an event like myocardial infarction, we want to understand what would we expect clinically to be the presentation, the management, and the follow-up of the disease, so that we can look in the data, try to see if we can see those patterns. And the more patients that we see that exhibit that pattern, the more confident we feel about it. And on the flip side, if we don't observe all of those kind of baseline characteristics, the more we might be skeptical of our definition. All right. So with that, I'm going to go give you a live demo of using cohort diagnostics to explore myocardial infarction, and then we're going to do, you guys are going to do angioedema yourself. Promise I will do it. There we go. All right. In the back of the room, can you read that clearly enough, or is it too small? Thumbs up? You can read that okay? Okay. So, what I'm showing you is a tool called cohort. I didn't do it.
Not touch the line.
Okay. Do our best here. So, we are going to use a tool called cohort diagnostics. You may or may not see it while I do it. This is a tool developed in the OHDSI community. Its approach to helping us understand measurement error is to perform systematic characterizations of a cohort. I'm going to show you an example of an acute myocardial infarction cohort, which is going to be similar to what Chan built for you earlier. But now the difference is going to be, rather than just creating the cohort, I'm going to try to understand what can I learn about the cohort. All right, we're going to do our best. So, I'm going to walk you through the acute MI example. but I want you to be thinking about how you're going to do this same kind of exploration for angioedema. The first thing I'm going to highlight on the very first tab here, cohort definition, is that the cohort diagnostics is a tool that can allow you to explore one or more cohort definitions. Each of these definitions are the same exact cohorts that you can and would have produced in Atlas. In this specific example, and I'll have this one pop up here, I'm going to show you results from the definition of acute myocardial infarction, which, just like Chan had showed you, is going to be people who have a conditioned occurrence of a code of acute myocardial infarction. One slight difference in this definition is I'm going to require that these acute myocardial infarctions occur in a visit that involves an inpatient or ER visit. So Chan's definition that he created, if you go back and look at it, he just said, find me any condition occurrence. But I'm going to restrict this to those that have that are hospitalized events. My rationale for that is because, as I described, we would think that most myocardial infarctions, if they're real cases, would result in a patient presenting either in the emergency room or the hospital because it's a real serious event. You wouldn't have a heart attack and just go to your GP and be sent home normal. All right. We'll make the best we can with this flickering back and forth. Wire number 2. Alright, another wire. Alright, I'll try this one out. See how that goes. Okay, let's see how that goes. So the first thing that I'm going to highlight here, on the left-hand side, I've now selected the tab called cohort counts. And we can basically see from the data how many myocardial infarction events we've observed under this definition. We can see in this particular case, we have 38,000 myocardial infarction, 38,000 persons who have had at least one myocardial infarction event, and that's 40,000 records. You notice the difference between those. That is suggesting that there is at least there's 2,000 more events than persons. That is to say, some people can have multiple myocardial infarction events. Remember, Chan was describing the importance of understanding that there's both cohort entry and exit. And indeed, clinically, it is the case that some people who have a heart attack may go on to have another heart attack. And this is recognizing that we are observing some people are having multiple heart attacks. So already at just a face validity perspective, we can ask ourselves the question of, is the number of recurrent events we are observing, is that something that's clinically plausible, or is it too high, or is it too low? One of the most basic questions that we have to ask ourselves when we think about our clinical description is it a clinical event that can recur, or is it the type of chronic disease that once it happens, you belong to that health state? So if myocardial infarction was a chronic disease, we would expect the number of records to equal the number of people, because once you enter that chronic disease state, you stay in that state forever. However, because we've treated this with the possibility that the event can recur, we are observing that we are having a few recurrent events. The second thing that we can look at is the incidence rate. And I'm going to just set this down to something low and generate a plot here. And what I'm going to summarize here is the incidence down here. I'm showing you now the incidence of myocardial infarction in the pharmacometrics database, stratified by age, which are represented in the columns, sex, which is represented by the colors, the greens being males and the orange being females, and calendar year, which is represented on the x-axis. So from a clinical perspective, we know that heart attacks are events that are more likely to occur in an older population than a younger population. So we would expect to see higher numbers, and this is the incidence rate on the y-axis. So we expect to see higher numbers as age progresses, and we see that. We also know that myocardial infarctions are more observed in males than females. So we would expect to see the green line above the orange line, and we see that. So that's kind of reassuring. What we also would expect is that this pattern over time should be relatively stable. That is to say, there has not been any large event over the last 20 years that would make us believe that the true rate of myocardial infarctions has drastically changed in the world. And here you can see, if I ignore these last two, hide these from you, you can see that indeed for these other age groups, the pharmacometrics database is relatively stable across calendar years. However, if we look in the age 70 to 79, we see an interesting pattern that might give us pause when thinking about using this definition in this data set. Because you can see from 2014 to 2015-16, there's an observed rate in the 70-year-olds that then drops down and reaches a new stable point. The point of this cohort diagnostic tool, to be able to explore these things, is to understand that this pattern exists in the data and to think about why might that be happening. Is this an artifact of the pharmacometrics data set? Is it an artifact of the coding structure that we define? By being able to observe these patterns, we can interrogate and explore them further. I'm going to skip around here in the interest of time here. I'm going to now jump over to the Visit Context tab. And the Visit Context tab is helping you understand what type of healthcare events, or what kind of healthcare experiences do patients have when they enter a cohort. And what this is specifically describing are what types of events do patients have before they had a heart attack, while they were having a heart attack, on the same day they were having a heart attack, and after they were having a heart attack. And so as an example, I'm going to just sort in descending order on simultaneous. We can see that most of the patients who had a myocardial infarction, it occurred on the same day as the start of an inpatient visit, 28,000 of these events. The next most common was an emergency room hospitalization, followed by outpatient hospitalization, inpatient hospitalization on your way down. Now what you also observe, though, is here we've got 2,300 cases where it says during, which is basically to say during this inpatient visit, there was a code for myocardial infarction observed. And this is another example where we may have index state misspecification, because it's likely the case that a person entered the hospital because they had a myocardial infarction. However, in the data, it is possible that the diagnosis code may be recorded sometime elsewhere during the hospitalization. For example, in many claims databases, such as the pharmacometrics database, there may be a discharge summary, which is basically the summary of diagnosis codes that occurs at the end of the hospitalization. And if we were to observe the diagnosis of heart attack at the end of the hospitalization and not correctly attribute it to the start of the hospitalization, then we could falsely claim that the MI happened when they were leaving the hospital instead of the MI happening as the reason they entered the hospital. And this is telling us that most of the time it looks like heart attacks are observed on the start of the visit, but about 10% of the time, myocardial infarctions are actually observed. The diagnosis code is observed during the hospitalization, which suggests that we have some degree of index date misfixication, though it's not totally too bad. The next thing I will share is cohort characterization. So what I'm going to do right now is I'm going to select the myocardial infarction cohort, and I'm going to summarize what are the events. I'll say what are the conditions, and while that's reloading, what I'm going to show you is how we can look at what data co-occurs with a myocardial infarction so that we can understand whether or not we observe anything that may be indicative of a sensitivity or a specificity error. So I mentioned, for example, that we would expect that people who really had a heart attack, some of them would actually present with chest pain. And those that really had a heart attack, probably some of them would have gotten an electrocardiogram. And those that really had a heart attack, some of them would have a PCI or CABG procedure as a treatment. And the idea behind cohort diagnostics, if I can never get it to load up, is that we can actually quantify the proportion of those events, of those MI events, who observe chest pain before having the event, or observe electrocardiogram on the day of having the event, or observe PCI or CABG on or after the day of having the event. Let me go to characterization. Select conditions, procedures, generate this table. And group by time. So what I'm not showing you, what I will be showing you, is I've taken my myocardial infarction events, and I'm now showing you the proportion of people who have each of these different concepts in time windows proximal to exposure. So actually you can see this very top one here. We'll start with chest pain. So we can observe the clinical concept of chest pain, and what we can observe is that 30% of patients who entered our cohort of acute myocardial infarction also had a diagnosis of chest pain on the exact same day. That is to say, when they had a heart attack, they also had chest pain 30% of the time reported. 30% of the time they had chest pain reported in the 30 days following the event. 10% of the time they had chest pain in the month preceding the myocardial infarction. So chest pain is being observed somewhat within the myocardial infarction cohort. Now, we might not necessarily expect that everybody would have chest pain reported, but the fact that we can see a good proportion of folks may be encouraging. I'll look for that electrocardiogram. And we can see here's an example of the code, whereby, scroll over so we can see a little bit better. An electrocardiogram procedure in this data set, 60% of the people who had a myocardial infarction had an EKG on day 0. So the majority of our MI cases actually had an electrocardiogram. That's good because that's what would be expected to be a diagnostic procedure to identify that myocardial infarction. Another 50% of these patients had, and could be some of the same people, had an electrocardiogram in the month following. So we're seeing a large proportion of patients who have an electrocardiogram. Now, if we are interested in treatments, here is a code for a PCI. I should drag that out so you all can see that. So adding a stent as part of the procedure, as a treatment for the management of the MI. And we can see that 10% of these patients get a PCI on the same day as their heart attack, and another 10% get it within a month. So the idea behind this tool is to be able to give you some sort of sense of how often the characteristics that you would expect to see occur and when they occur. Now, this tool can also help you with trying to determine index date misspecification. Let's see if I can find a specific example here. I'm going to change my report to now, instead of looking at conditions and procedures, I'll now go look at drugs. I'm simply going to select the drug report, and I'm going to run this again. And so now I'm able to look at different drugs and how often they are used in this cohort. And in this particular case, I can see that heparin, which would be an anticoagulant that would be used in the case of cardiovascular complications, was used 10% of the time on day 0. I'm going to actually sort on seeing what things occur in the time preceding, and I don't have anything that's more than 1%, so it's not going to help me here. Here. Oh, that's right. Let me just check one more thing to see if I can see if there's anything interesting. I'm going to look at, let me go back to procedures. Lost my screen. So in this particular case, as I'm looking for other treatment procedures, we had looked for PCI before. We're looking for, you can see, catheter placement for coronary arteries and coronary artery bypass. What I'm looking for is to see whether or not I'm seeing any of those events occurring before the diagnosis. If we saw large proportions that were occurring in the days preceding the diagnosis, we would know that we had index date misspecification. The fact that, for example, that I don't see any proportion of patients having a coronary artery bypass in the 30 days before the diagnosis gives me reassurance that I'm looking at the right types of events. So this idea that you all may have some clinical understanding of a particular target, a disease of interest, this tool allows you to use your data to be able to understand whether or not the background incidents make sense, what specific diagnosis codes are being used to identify cases, where are you receiving care, and what other types of clinical attributes do you observe. And what we found through various studies within the OHDSI community is that this tool can help to identify problems in your phenotype definitions and help you to correct them. In particular, I guess I'll just go back to this visit context here. Chan's definition, he did not require that you be in the hospital. And in this particular definition, I did require being in the hospital. We actually have a paper that's currently under review that highlights that across the OHDSI community, we've looked at this question of where do heart attacks actually happen. And it turns out that we observe somewhere between a 30% and 100% increase in the number of heart attacks we observe if we don't require a hospitalization. That is to say that the rate of heart attacks we'd observe in this Pharmetrics database would be 30% higher if we didn't require that they happen in an emergency room or a hospitalization. And as we investigate that, we can actually see that those other 30% of events are probably not real. Those are the people who didn't present with chest pain. They didn't have an EKG. They didn't have a PCI and a cabbage. Instead, they look like suspicion of myocardial infarctions that are not probably real. And that was an insight that we were able to gain by looking across a range of databases using this tool, Cohort Diagnostics. Okay, so your exercise, and I'm going to give you this URL to explore, is I want you to think about angioedema, and I'll provide you one brief clinical vignette for you to think about as you play with this tool. And hopefully our TAs can walk around and help you as you're exploring yourself. So I'm going to remind you, angioedema is localized subcutaneous swelling. This is something that we would oftentimes present with some sort of serious rash. It can be associated also with urticaria and anaphylaxis. It can occur, most commonly occurs somewhere in your face or throat area. Generally, what you would observe when you saw, or if you were a person who presented with angioedema, you may be treated with epinephrine as a way to try to immediately reduce the swelling. And you may also see other types of comorbid acute things like anaphylaxis as related to it. What you wouldn't expect to see with a case was a drug-induced angioedema is other things that may cause the swelling. So like if you saw a bee sting or some other sort of event, then maybe the allergic reaction would be due to something other than the drug. So, actually I'm going to go through it super quick. Your homework during lunch, that I'm going to guess not everybody did, was to create a cohort definition for angioedema. So just to give you a quick reminder of how to do that in Atlas, if I were to click New Cohort, I could click Have a Condition Occurrence of, I could create a concept set or import a concept set for angioedema. I could require that I'm going to select all angioedema events. I could say that an angioedema event is something that has to be separated by some period of time, let's say 90 days, and that each event by itself is really only a day long. So there in 60 seconds, there in 30 seconds, I have just created a cohort definition for angioedema, which would be a totally plausible definition that you may see. The hard part isn't creating a definition. The hard part is knowing, do we trust that definition? And so what I want all of you to do is to go out to data.odyssey.org/Odyssey 2020, Odyssey 22 CD tutorial angioedema. I'm going to see if I can maybe link that big on the slide so you all can copy that and read it. But you're going to go out to this cohort diagnostics, and I want you to just take a few minutes to explore and see whether or not you trust that definition. I'll just paste it on the slide so you can see it a little better. There we go. Okay? So everybody go to this URL right now. And our TAs will help you in case you're having any questions about it. But I want you to just take 5-10 minutes and explore cohort diagnostics yourself to see whether or not you trust our definition of angioedema. Raise your hands if you have questions or any problems getting to that website. data.odyssey.org/Odyssey 2022 CD tutorial angioedema. Raise your hand if you've gotten onto the website. We're still typing it in. When you get there, you should be able to be in cohort diagnostics. You can see our definition of angioedema, and you should be able to explore, understand what you observe in terms of its incidence, what codes make up that event, where angioedema events happen, and what are the characteristics about angioedema that you observe. So as an example, on the cohort counts, you should be able to observe that there are 20,000 patients who have at least one angioedema event, 22,000 records. So that's telling us that there are at least 2,000 cases of recurrent events. You can think about how that matches up to our clinical understanding of this acute event that could occur, some spontaneous swelling. It is possible that one person could have multiple angioedema events, though as this is telling us the proportion of people having recurrent events is relatively small. You may want to explore the incidence rates, try to see whether or not the patterns that are being observed make sense. When we see an incidence rate plot, we're asking questions like, do we see a pattern by age? Do we see a pattern by sex? Do we see a pattern over calendar years? If we look at the incidence rate here, we see an interesting phenomenon that from ages 10 to 50, we're observing that the incidence of angioedema is higher in women than men, while it looks like it's more consistent after that. Does anybody have any insights into why angioedema may be occurring more in women than men?
Beekeepers.
Beekeepers? So women are more likely to be beekeepers.
Strange. Can I refresh? Oh, it came up. Oh. Yeah, it's just slow. I think it just popped up and I.
We can see the pattern is relatively stable over time.
If you go here,
which we take some reassurance in that we're not seeing something that's radically changing.
Wi-Fi? Yeah, no, you should go to the OHDSI.
So the incidence rate that's being plotted here is just between 0 and 1.5. And so while we do see maybe very slight increase in the age, on a relative proportion, as if these are relatively rare events and they're relatively stable over age years.
Now it should be faster.
No, women are.
So what he's seeing here right now, there we go to incident rate.
We may be interested in understanding where angioedema events are occurring.
Let's change it to 10.
We can look at the context. If I sort on simultaneous, we can see
Give it a second.
we observe a lot of them. Majority are happening in the outpatient office visits.
Yeah, of course.
However, some are happening in the emergency
So why did it
room.
reset?
And some still are happening in the outpatient hospital visits. Relatively few of the events are happening in an inpatient visit. That means they're staying overnight.
Oh, you can't do it now because this court diagnosis thing is yes, it's specifically for angioedema. Yeah.
Angioedema? Remember what I told you about it?
Oh, it's already there.
Yeah, so it's already generated.
Most of the time, it's an adverse event that
what
seems
this
alarming.
court
You might need to
diagnostic is
get
doing
managed for it, but
it is evaluating
relatively infrequently is it going to be
if
so
this
bad
cohort that you've defined
that you're going to need to be admitted
is
and stay at the hospital.
clinical correct or not
Indeed,
by
we can
showing
see
these
here
parameters.
the proportion of
And the
events
definition is actually
starts
back
out
in
at
Atlas.
least less severity
You go here,
up to increase.
you go here,
here.
and you close this one. So if you look for
You may be interested in trying to see what other things do you observe around angioedema.
NGOs. So it is actually evaluating if this cohort. So what you're seeing here right now is actually a pre-generated diagnostic of this specific cohort. So it's saying a diagnosis of angioedema. We're looking at everything, and we also said no angioedema within 180 days within the index state. So like 6 months. Yeah. And then
So if it's all about
he's also
bees, then we
defined it
expect
so
that
that
maybe we're gonna
the
see
angioedema event lasts just
bee
1 day.
stings
So that's
that are gonna be
Patrick's
co-occurrent
definition of
with
angioedema.
our
Now what he's
time
done
zero.
is he's showing us what the cohort diagnostics. So
First things
based on
first,
what he's
details
defined, we can now
slowly.
look at, for example, the incident rate of the specific angioedema and see. So first of all, you might want to check how many patients and events. So you would go to court counts. It would show you number of persons
So,
and number
for
of events.
example, we can
So
see,
if I remember
mentioned that
correctly,
we
it
may
was
see
20,000
things like
and
urticaria
22
as another
events.
diagnosis
So
that
one
can
person can have more than one event of angioedema, right? So
You see that
that's the
occurring in
insight
about
you can get
10%
from
of the
court
cases
counts.
in the month
Since this is
preceding the
an
month
acute
afterwards.
diagnosis, you can expect more than one, right? So that would be typical.
I want to test out Mark's hypothesis about
If
these.
this
so I
loads,
may
it'll be
just
great. But yeah,
search
so that's the court count. If you go to
my text box here to see
you
if I
can
see
see
anything associated
how
with
the
insects or
incidence
bees.
differs between male and female, and as well as the age groups. So, for example, 0 to 9, 10 to 19, and all the way around,
So
right?
all of this pre-programmed
There.
software,
Exactly.
a package, and you just for us, we just click on it, it just generates automatically.
Yeah, so this court package, I think it is
The
a
most
court package.
common
You can run it
conditions
against your
that
cohort.
co-occur
So if you create another cohort,
Angioedema
you
appear to
can
be
go to the
urticaria,
court diagnostic package and you can run it yourself to
allergic
see
rhinitis,
if
allergic
your court has
disposition,
been run
which we expected to see
successfully. But this
before.
one, it's not something that we're doing
Swelling.
in this
I know.
tutorial today.
Fibro is
It could
the
be something
symptom
that you could try
actually
out
starts
later.
things.
Yeah,
Allergic urticaria,
yeah. So if you
eruption and rash.
let's change it to
These are
10
all
like
things
you did,
that we're-
and if you generate it,
symptoms
it'll
that
give
we
you
might be
plots
looking
like
at.
he was seeing.
So this can give us some
Let's
sort
give it
of
some time.
comfort
Loading.
that we may be actually looking at real angioedema events.
So what he's looking at is which function there.
It's It's the characterization function. Yeah. So if you go here, actually, I had it loaded.
I could also go look to see what are the specific codes that are getting somebody qualified into this cohort, which is the index event rank down tab.
Up until 1 month before the index date. The next one is within 1 month of the index. Using on the index as well as the first one after the index.
That interested in this
30
case,
to
we'll
1 month
go back.
to 12 months after the index. So you're looking at 5 different time periods, and you're getting results. So for example, I said I want to look at the diagnosis and the procedures of these specific 20,000 people. So if you, okay, this is looking for so if you group it by the times, you can see which.
All right, so while that's loading, does anybody have any questions about
the most
cohort
prevalent in
diagnostics?
each of these time frames?
Do you have any interesting
From a
observations
clinical
they saw when they were looking
perspective, if
through
the
it?
data you see makes sense, you can have
Does anybody
more
understand
confidence
cohort
over what you
diagnostics
have
at all?
applied on your specific cohort. So this is basically helping you understand.
Raise your hand if you're going to use cohort diagnostics in your next study.
Used is really clinically
Okay.
relevant and catches
It's a
the
handful.
patients that you want to catch.
Okay.
Yeah, that's the entire, I guess, the purpose of this specific tool.
All right. Well, both the app for angioedema and for myocardial infarction
So
are.
there you go. So it's showing that
I'm going to transition to talk about
myocardial
characterization.
angioedema. Actually, there
But
are some
before I do, I
incidents.
just want to
There's no big
summarize
difference
what
between
we're trying to
males
show
and
you with
females
this
in the
segment.
younger ages, but if you go to
When
the
we want to
40s,
generate
you see a lot more
evidence
females
about a
getting this.
particular
So
characterization,
by looking at this,
estimation,
so
or
30s and
study,
40s, right, you might
we
think,
have to
okay,
create
is
cohorts.
angioedema really
But in
more
order
common in
to
women? So that would
use
be a
those
question that
cohorts,
you would
we
be
should
asking.
first have
And
confidence
if
that
it
the cohorts
is, you would have
represent
confidence. But
the people we want.
if your data is showing the
Within
opposite,
Odyssey, we're building
that
a
means
range of
something must be
tools
wrong,
to
right?
support
So
you
these would be
in making
some
sure that you have
insights that you would be
confidence in
getting
the
and thinking whether
We've
what I
actually
define
found
is
that
correct.
cohort diagnostics is a very helpful tool to help you
Correct.
do that iterative
Correct.
process
Exactly.
of understanding your
Exactly.
cohort.
So the core you
And we've
define is the
also
most
found that it's actually
important
very helpful when
element
it
of
comes
doing a
time for
study,
you to
right?
write
Whether
your
you're capturing the right
publications,
patient or not.
to
So
be able to say that you
this is
reviewed your
showing a lot
cohorts
of ways
using
in
cohort
order for you to
diagnostics.
see if
And in
these
fact,
are
in
correct
many
or
of
not.
our recent
Yeah.
publications, we
Minus
have
the
provided the URL just like
I think a lot of
this
people
as
are
part of
doing
our
that.
papers to demonstrate this scientific best practice. And so I encourage you to take a look at this. Cohort Diagnostics is an R package. It's part of our Hades library. So once you create a cohort, it is easy to run the package, produce one of these shiny maps, and then explore the results yourself. Okay. Stand up if you're excited by cohort diagnostics.
Yeah, so it would, if your database is huge, running
All right.
these kind of things.
Stand up
also
and
takes
jump
time.
on one leg if you are not excited by cohort
It would be
diagnostics.
different also if you have a very good server, an expensive server.
Everybody
it will run
just
faster,
stand up.
But still,
Based on your server.
yeah, so based on your server as well as how big
Right.
your database size
And
is.
stretch it out. I know that
So
I'm
it's very
right after lunch.
a lot of
so
things to consider if
stretch
you
it
want
out.
to look at. So if you want something to be fast, you need to have a very